The VIII study is first of its kind prospective evaluation of doing very early prophylaxis with Emicizumab in infants from shortly after birth. Now the background for this is that traditionally, even though prophylaxis is the standard of care for patients with severe hemophilia A, when applying it to infants, when we had to rely on factor VIII prophylaxis, that was pretty challenging in the first year of life. Factor VIII clotting factor concentrates have to be given intravenously, usually fairly often because of the short half-life. But that means that most infants usually don't get initiated on prophylaxis until about a year of age. So we've had this treatment gap in the first year of life where infants usually are just left without protection from prophylaxis, and we have to react to bleeding events. Now, thankfully, infants aren't particularly mobile in the first year, so that reduces some of the risk, but we still see spontaneous bleeding in this age group. We still sometimes see bleeding into joints. These are the hallmarks of hemophilic bleeding. But even worse, we know that there's a concerning rate of intracranial hemorrhage that can occur in infants. It's as high as 4 to 8% over the course of the first year of life if an infant is not yet on a prophylactic therapy. Even though Emicizumab has been approved for all ages and all severities, there was a lack of data in the youngest infants because they were underrepresented in the clinical trials. So VIII set out to enroll patients, get them started on Emicizumab prophylaxis as early after birth as possible, and see if we could impact reducing the risk of intracranial hemorrhages, maintaining effective prophylactic bleed control. But it's also allowing us to explore one other important aspect of consequences of routine exposure to factor VIII, and that is we know that infants, about 1/3 to 40% of them will develop inhibitor antibodies against factor VIII. So if we can substitute for factor VIII with Emicizumab, we could potentially reduce the number of exposures to factor VIII and perhaps have an impact on the natural history of inhibitors as well. So what did we do? We enrolled 55 infants into this study. Half of them were under 3 months of age at the time of enrollment. The others were between 3 months and up to 12 months of age. Just about half of them were previously untreated patients, so they'd never had any prior factor VIII exposure. And then the others were what we would consider minimally treated patients. They could have had up to 5 exposures to factor VIII. Now it's interesting, coming into the trial, we had opportunity to see what kind of bleeding events these infants had before they got started on Emicizumab. And about 2/3 of the infants had exposure to factor VIII because of bleeding events. And about a third of these were spontaneous bleeds, which is the hallmark of severe hemophilia. The 55 patients who were enrolled, we had patients who were able to get onto therapy as early as, a couple of weeks after birth, and then all the way up to about 12 months of age. The efficacy endpoints we looked at were treated bleeds, all bleeds, so that was a bleed whether it required a bleeding treatment with a factor product or not. We were able to look at spontaneous treated bleeds, and then we're also able to look at treated joint bleeds. And the overall efficacy showed that the treated bleeds was an annualized bleed rate of 0.4. All bleeds was an ABR of 2. But interestingly, there were no infants that had a treated spontaneous bleed, and there was a median of 0 for treated joint bleeds. And then if we look at the proportion of infants that had 0 bleeds, over half of the infants had 0 treated bleeds over the course of the study. And they were all followed over a 52-week period. The way we designed the trial is all the infants got a loading doses to take them up to steady state, so it's a weekly subcutaneous injection, and then all the infants were on the same maintenance regimen of every 2-week dosing. Once they got to a year, they could revert to any of the 3 approved maintenance regimens, which is a weekly, every 2-week, or every 4-week injection. So the efficacy period we're talking about is the infants during that 48-week of maintenance period after they got up to loading dose. One interesting question that we had going into this trial was whether the infants could even generate a satisfactory level of emicizumab in their plasma, because generally monoclonal antibodies don't have favorable pharmacokinetics in the youngest infants. So we did see a slight increase of the emicizumab levels over the first 6 months, but actually all the infants were able to achieve very good levels. In fact, even higher than we've observed in some of the other Haven trials in older children and adults. And so I think this shows that we are able to get them up to a level that should provide the efficacy that we observed. Some important safety aspects of the trial. No new safety signals for this trial compared to what we've already learned from other Haven trials. We did evaluate immunogenicity on 2 fronts. So we were able to look for anti-drug antibodies directed against emicizumab, as well as any factor VIII inhibitors that occurred due to factor VIII exposures. So first, related to the emicizumab anti-drug antibodies, all 55 of the infants were evaluated over the course of the study, and none of them have demonstrated anti-drug antibodies. With respect to factor VIII inhibitors, half of the infants have not had any exposures to factor VIII, so of course no immune response to evaluate. If they did get exposure to factor VIII, we had instructed the investigators to get a factor VIII inhibitor assay after they had 3 exposures or 2 consecutive factor VIII exposures back to back. So as it turned out, 24 of the 55 infants have had a factor VIII inhibitor evaluation, and we've only identified 2 infants that had evidence of a inhibitor. They had multiple exposures to factor VIII, either related to bleeding or procedural exposures, and this is probably why they manifested at this point in the trial. But overall, that gives us an inhibitor risk during this first year follow-up of only about 3.6% for all of the participants, and less than 10% amongst those that have received factor VIII exposures to date. So we're going to have to require longer follow-up to see the full natural history. But I'm impressed that emicizumab delivered in the efficacy, and it's substantially reducing the factor VIII exposures. So hopefully there will be some impact on the natural history as we see going forward. So we now have the opportunity to continue to follow these infants over the next 6 years, actually, where we'll have more data on safety and efficacy. And then importantly, it's planned at the end of the study at 7 years of follow-up, they will all be evaluated by joint MRI exams, and that will give us some important information about long-term joint health.